So in this video, we're going to be talking about labs that we typically get in the hospital. So we're going to focus on the general ones, and then at the end, we'll go over the ones specific to the cardiac case. So there are two sets of labs that we typically get for every adult patient that comes in the hospital. The first is the CBC. So that's the complete blood cell count. That's what we look at. That's what we use to look at the white blood cells, so which is a marker of inflammation, and then the hemoglobin, which tells us if the patient is anemic or not, and then also the platelets, which tell us how many platelets there are. The other is the basic metabolic panel, which looks at electrolytes and kidney function. It also includes glucose in there too. So we typically get these two for pretty much every adult patient coming in. For pediatrics, it's a little different. Peds, we try not to poke them as much, especially if there is not something specific we're looking for in the labs. Now, the other two sets of labs that we have here are for the liver and the pancreas. The liver labs I get pretty often because we have patients with cirrhosis coming in, and then the pancreas labs I get pretty often as well. Not as often as the others though, but usually for somebody with pancreatitis, we'll get a lipase, and I've been seeing that more often. But let's go ahead and focus on the two main ones, the CBC and the electrolytes. So the CBC shows us four different values: the white blood cell count, the hemoglobin, the hematocrit, and the platelet. So the white blood cell count, as it probably sounds like, is a count of the white blood cells. So what does this tell us? White blood cells are our immune cells. So it tells us how ramped up the immune system is. A lot of people will say, well, it's an indicator of infection, and I agree to some extent, but the way that I like to see it, it's not so much infection, it's more inflammation. So you can have an elevated white blood cell count and not have an infection. A lot of times it's a product of inflammation. If we think of what inflammation is, it's an activation of our immune system to address some type of insult to the body. So whether that be bacterial, whether that is autoimmune, where your own white blood cells are attacking itself, but there's some form of inflammation in the body, and the white blood cell count gives us that indication that there is something going on. So other than inflammation or infection and autoimmune disorders, what else can cause an elevated white blood cell count? So pause it here and try to answer it for yourself. So another thing that can cause an elevated white blood cell count is cancer, right? So leukemia will cause an elevated white blood cell count because it's a cancer of the white blood cells. Same thing with lymphoma. The lymphoma won't cause as dramatic of an increase in white blood cells. But if you have a significantly elevated white blood cell count, and I'll give you the normal values, but like 10 times as many WBCs, or even 5 times as much, that it can be an indication of something like a blood cell cancer. But for the most part, we're generally looking at mild elevations to mild to moderate elevations. And I'll go through the values right now. So the typical range of a normal white blood cell count is anywhere between 4 to 11,000. Now, each lab is different. So for all of these values that I'm giving you, it's with a caveat that if you have a different lab reference range, you should go by that one. But for our purposes here, 4 to 11,000 is the normal range. Anything below 4 is abnormal, anything above 11 is abnormal. Now next we have hemoglobin. Hemoglobin is a protein that's found in red blood cells that transports oxygen from the lungs to the rest of the body. Now when hemoglobin is low, that's when we have anemia. And so I'm sure you are all aware of anemia. There are a bunch of different kinds, and that's probably out of the scope of what I'm trying to teach here. If we have a case on a type of anemia, or somebody comes in with anemia, I'll definitely be going over the more minute details of this. But for the most part, you see a hemoglobin that's low, you can expect that their blood count is low. After hemoglobin, we end up with hematocrit. Now, hematocrit is related to hemoglobin. The formula that we typically use is hematocrit equals about 3 times the hemoglobin. So what is it? So hematocrit is basically if you take a vial of your blood and you spin it down, you're gonna have part of it separate into red blood cells, the other part of it separated to the actual like liquid, the serum. And so hematocrit is how much of your blood is actually red blood cells. So the normal value, the shortcut to get to the normal value of what your hematocrit should be, is whatever your hemoglobin is times 3. And so this is helpful to know in people that you think might have thicker blood, have a proliferation of red blood cells that may be inappropriate, like polycythemia vera. But for the most part, for every day that you're rounding on a patient, I don't pay attention too much to the hematocrit. I pay more attention to the hemoglobin. And lastly, you have your platelets. Now, your platelets are basically what it sounds like. It's a count of how many platelets you have. So, what are platelets? Platelets are small, so very small cells that kind of float through your bloodstream and get stuck onto places that they need to plug up. So, if you have a red blood cell vessel here, and then you have a break here, and now you're leaking blood out, well, the platelets will come in, notice that there's this break, and attach here. And so as they start attaching, they can become more sticky and they start to aggregate. And then they plug up this hole so that no more blood can come out. Eventually, this platelet clump will degrade and you'll have fresh new lining of your blood vessel whenever it repairs. But the important thing about platelets is if you don't have enough, you're going to be more prone to bleeding because you can't stop these breaks in your blood vessel or these bleeds. So the normal value of platelets is between 150 to 450,000. And so in the morning, we get all of these labs to check to see how our patient is at baseline. A lot of times we're just making sure that there's nothing new popping up, unless you have something that you're specifically looking for, like if somebody's having a bleed in their stomach or their intestine and you're trending the hemoglobin to make sure that they're not dropping too far. So next, let's turn to the BMP. The BMP is basically a measurement of your electrolytes and also your kidney function. You have glucose thrown in there, but a lot of times you're not really actively looking for glucose issues. So with the BMP, the first thing that we look at is the sodium. The sodium measurement is actually pretty difficult for a lot of residents and medical students to conceptually understand because the measurement of sodium is not a measurement of the actual amount of sodium in the body. That's not what we use it for. What we look at is we use the sodium as a surrogate of your fluid status, meaning how much free fluid do you have in your body? Because if we think about chemistry and osmolarity, we know that wherever there is a higher concentration of solutes, so like your sodium or if glucose is really high, your glucose in dissolved into a solution, wherever it's higher, we know that water is going to flow. And so if the gradient of sodium out here is higher than it is here, then we know that water is going to go from inside the cell to outside the cell. And so your cells and your body are going to try to maintain that homeostasis by balancing these electrolytes. And so it's very important that we get these values so that we know, what is the patient's fluid status. Because if their sodium is very low and we give them fluid, like IV fluid with high amounts of sodium, well, we're making the outside a lot higher than the inside. So all of these cells are going to shrivel up and all the free water is going to flow out of the cells. And we don't want that because that can cause a lot of problems. And so that's what we typically think of when we think of sodium. So all of that is to say that sodium is a measurement of free water, right? So if you have a high sodium concentration, that means that your free water is low. You're very concentrated. So if you think of like your urine, when your urine is very concentrated, it's dark and it smells a little bit more because there's more things dissolved in it. Your sodium content in that urine is going to be high. Now, when it's almost clear and it has a little bit of tinge of yellow, well, your sodium content is low because you have a ton of water in there, not as much sodium. So what are some of the things that will elevate sodium? Well, dehydration, of course. And then that makes sense because, like I said, when the actual amount of water that you're taking in or in your body system is low, your sodium is going to go up because it's more concentrated. If you think of somebody that has diabetes and their glucose is also very high, well, in your bloodstream, now you have a bunch of glucose and you have a bunch of sodium. So the overall concentration of things dissolved in your blood is very, very high. So what is your kidneys going to want to do? Well, they're going to want to try to get rid of as much of that as possible. And so what they'll end up doing is they're going to try to excrete some of that solute. So they're going to try to get rid of some glucose, and they're going to try to get rid of some sodium. Well, they're both going to be taken care of. And so if that's the case, your sodium is going to go out, but so will your glucose. But more free water is going to go out. And so as the free water goes out, well, you're losing more water than you are sodium, so your sodium is going to go up. Well, we talked about things that will increase the amount of sodium, and honestly, there's a ton of things that will increase the sodium in your body. And this is not a lecture on sodium. We would literally be here forever if it was. But let's look at things that can decrease the sodium. So if we said the increased sodium is due to not as much water, so you're dehydrated, there's less water to dissolve the sodium, well, the opposite is true. If you have too much water, you can have a decreased sodium because there's more water than there is sodium. So what would cause that? Well, one thing is congestive heart failure. In congestive heart failure, it's basically a failure of the pump, your heart. So if you think of your heart as a pump that is going to pump water from in here to out here, well, now you've blocked this pump. You can no longer push too much water out. So it starts to build up in your system. And as your water starts to build up in the system, you're not getting rid of it through the kidneys. Now, too much water means that you have a mismatch between the water and the sodium. And so you have more water than sodium, so your sodium will decrease. But it's important to remember the actual sodium concentration is not going down. It's the relative concentration of sodium as compared to the concentration of water that is going down. So this ratio is going down because the water concentration is going up. Now, that's for sodium. Now, when we look at potassium, the opposite is true. Whereas sodium had more concentration outside of the cell and less inside of the cell, potassium has more inside of the cell and less outside of the cell. Now, it's very easy to get lost in the weeds with all of these values and meanings for these electrolytes. And in all honesty, it's not particularly relevant for what we're talking about for chest pain. And so I'm going to kind of gloss over the next few ones. Potassium, though, is important for the way that the heart actually conducts the signals to make it actually beat. Potassium gradients are present in pretty much all cells, but they're very important in cells that conduct electrical signals. So those are cells like neurons, or for us, in our case, it's going to be like muscle cells, so the cardiac muscle tissue. And so if there are derangements in the actual concentration of potassium inside versus outside the cell, you're going to have changes in the way that the heart muscle conducts these electrical signals or electrical potentials. And so that's one of the reasons why maintaining a normal range of potassium in patients that are admitted, especially for cardiac issues, is very important, because you can easily go into an arrhythmia because you have either too high potassium concentration, but also too low concentration. Because I don't want this video to be 30 minutes long, I'm going to hold off on talking more about potassium because it is very important for arrhythmias, but technically for what we're talking about in this section of chest pain, it's not as important. So in the future, when we do talk about arrhythmias, I will dive deep in the way that the cardiac muscles actually conduct these signals so we can understand why potassium is so important. But to move on, the chloride and bicarb are also relatively important. The chloride, not so much. There are only a few things that we really look at for chloride, but for all intents and purposes, it's generally ignored. But the bicarb is important because it tells us what your acid-base status is. So if the bicarb is very low, well, that means that you've been using a bicarb, which is a buffer. It's a base buffer. You're using a bicarb, which means that there's a lot of acid in your body. And so low bicarb tells us that your blood may be pretty acidic. High bicarb tells us that it might be alkaline. And so when you have something like lactic acidosis, where the lactic acid within the cells is now seeping out, and your cells are breaking down, that can cause a decrease in your bicarb because you're trying to buffer that extra acid. So the bicarb is actually a very good way of testing what the acid-base status of a person is. So for instance, if you have a very bad infection, your lactic acid goes up like we talked about before, your bicarb is going to go down because it's buffering that system. And this is it's not a super invasive test, whereas if you wanted to get a true value of what the acid-base status is and look at the pH and everything like that, you would typically get something like an ABG. An ABG is an arterial blood gas, and we typically do that with patients that have respiratory issues where their lungs are failing, but it's an arterial blood gas, so it's not a typical venous draw. It's through the radial artery typically, and that can be very painful. And if you hit the artery wrong and it bleeds a lot, it can be pretty messy. So we typically don't like to get those unless we absolutely have to. So the bicarb is a good surrogate for what your acid-base status may be. Now, there is a reason why I drew a kidney next to this section of the BMP. All of these electrolytes are affected by how well the kidney is able to excrete these electrolytes. And so if the kidney's not functioning well, you're going to have derangements in all of these electrolytes. But a more specific type marker of the kidney function is the BUN and the creatinine. Both of these are good markers to tell whether or not there is any kidney injury. So if the BUN and the creatinine elevate, then that tells you that there's some type of kidney injury. Now, it can be chronic or it can be acute. So if something is happening over a long time and your BUN and your creatinine are elevated for a long time, well, that's most likely a chronic issue, which you would get from something like diabetes or from hypertension. But if it's something acute, like let's say my baseline creatinine is 0.7 and now something happens and my creatinine is now 1.8, well, that's a pretty big increase. So what happened? Well, there's a lot of things that can happen that can cause kidney injury. But the way that we typically break it up is, one, do we have not enough fluid going into the kidney? Two, is there something wrong with the actual kidney itself? Or three, is there a blockage down away from the kidney that's causing a backup of fluid and now you're no longer able to drain? So in medical terms, we call that pre-renal, which is before the kidney, intrinsic renal, which is within the kidney, or post-renal, which is after the kidney. Now, the most common cause of kidney injury is pre-renal. So in acute kidney injuries, so an AKI, pre-renal causes are typically what's most common. And so if we think about things that will decrease perfusion to the kidney, well, that could be a lot of different things. If you have low blood pressure, you can decrease perfusion. If you have severe sepsis, where all of your vessels are dilated because there's a inflammatory response, usually because of some type of bacteria. Well, if everything's dilated, less flow is going to the kidney, and it's kind of going everywhere else. And so if the kidney sees less flow, it's going to feel like it's dehydrated, and there's going to be an injury. And then also just regular dehydration. If you're not drinking anything, you're going to have less fluid going to the kidney, and so you have a little bit of an injury. All of these are reversible for the most part. If you have a pre-renal kidney injury, those are reversible. Most of the time, we just give some fluids and everything gets better. But if it doesn't, you have to go back and reevaluate. Well, is there something inside the kidney that's wrong? Is it outside the kidney? And so on and so forth. So the BUN and the creatinine are great representations of kidney function. The creatinine, a lot of people will have varying values of the creatinine, so it's always important to know what the baseline is. Because even if you have somebody with a baseline chronic kidney disease and their baseline creatinine is like 1.2, well, if you go from 1.2 to 1.8, that's a pretty significant increase. So there might be a kidney injury. So it's less important to look at the absolute value of the creatinine. It's more important to look at what the change was. So did you go from 0.7 to 1.8 or 1.2 to 1.8? And if you did, man, there's some process going on that's injuring the kidney. And lastly, your glucose is just a measurement of glucose. There's not really much more to that. Now, let's move on to the liver function test. The LFTs are more helpful if you suspect some type of liver injury going on. So if somebody has liver failure like cirrhosis, that can be a good reason why you would want to get the LFTs. Or if somebody has evidence of jaundice, meaning that the skin and the eyes start to turn yellow, that's an indication that they're not able to excrete bilirubin, which is one of the waste products of of the body. And so the LFTs come in two different types. So one is the AST and the ALT. Those are both enzymes within the liver, right? The AST and the ALT, because they're enzymes within the liver cells, it tells us if there's an acute injury. So if you have your liver cell here, if there's something that breaks open that cell, that didn't work out very well, something that breaks open that cell, well, those enzymes are now able to spill out. And so things that are quick and can cause a very quick injury to the liver, like let's say I overdose on Tylenol, well, that's going to cause some pretty severe injury to my liver. And these enzymes are going to spill out because those cells are now disrupted. And so AST, ALT show acute liver injuries. Now, what about the T-bili? I said that the T-bili was a product of, it was a waste product of our body. Bilirubin is one of the end results of a breakdown of red blood cells. Red blood cells typically break down every 3 months. So the bilirubin, what ends up happening is if you have your RBC here, as the RBC ages and dies, it breaks open and you have bilirubin. Now the bilirubin gets transported to the liver to be turned into a conjugated form so that you can actually excrete it in the stool. Now, if you have your liver here, it's a terrible liver, and there was some blockage. So as the bilirubin gets drained out, there's some blockage. Well, you're going to have an increase in the amount of bilirubin that's brought back into your circulation and not excreted. And so bilirubin is a good indication of either a blockage here, or if there's something wrong with the actual liver itself, that it can no longer process the unconjugated bilirubin into conjugated bilirubin for it to actually be excreted. So the other way that you can have an increased bilirubin is if we are breaking down too many red blood cells. So if your average if your average lifespan of a red blood cell is 3 months, but instead you're now having an acute massive amount of red blood cell breakdown, well, you're going to have more bilirubin, which is going to cause the total amount in the blood to increase. It's called T-bili because there's also a direct bilirubin, but we're not going to get into that right now. So what I want you to remember about bilirubin is that this is something that the liver actually has to work on and change for it to actually be excreted. So if the liver no longer functions, if you have cirrhosis or liver failure, and you're no longer able to break this bilirubin down, your bilirubin is going to increase. And so it's a good marker of how well the liver is functioning. Now, just like the AST and the ALT were both markers of breakdown of liver cells, well, the lipase is similarly a marker of pancreas injury. So lipase is usually elevated in things like pancreatitis, which is basically inflammation of the pancreas. Now, inflammation of the pancreas can happen for a bunch of different reasons, but what we typically see is either alcoholic pancreatitis, where somebody drinks too much alcohol and now they have inflammation of the pancreas, or if you have a gallstone that gets stuck at the head of the pancreas because it's draining from the liver and it gets stuck here before it goes into the duodenum, well, now you have a blockage here. And the enzymes that are supposed to drain into the duodenum from the pancreas, well, now they're sitting in the actual pancreas itself, and it's actually just eating up the pancreas, causing inflammation and causing breakdown of the pancreas. So you would have an increase of lipase in both of those scenarios. So this is all great, but what should you know about for a chest pain case? Well, the white blood cell count is going to be important because it's a marker of inflammation. Typically, that inflammation is going to be because of some infectious etiology, but it's not always. The hemoglobin is going to be important just to know if there is some sort of anemia. The platelets are going to be important because if the platelets are too low, you can have a bleed, and technically, if they're very high, can be another marker of inflammation, but we won't go into that right now. The BUN and the creatinine are also going to be important, more so the creatinine because it's going to tell us whether or not the kidneys are affected. The rest, the AST, the ALT, T-bili, lipase, they're not as important for this case, but it will be in the future. Now let's focus on some more cardiac-related labs. So the big one that we always talk about is the troponin. The troponin, just like the AST and the ALT were markers of breakdown of the liver, the troponin is an enzyme that's found within the cardiac muscle tissue, and it is a sign of breakdown of the cardiac tissue. So if you have a heart attack, if you had some type of blockage, and now this muscle right here has all died, well, those cells are going to now be open, and that troponin is going to come out of the cells and into the bloodstream. And so you're going to be able to see the troponin elevate when you have cardiac injury. So if a troponin is elevated, you know that the heart cells are seeing some type of hypoxia, or they're having some type of decreased oxygen delivered to them. Now, just like we mentioned before, a cardiac injury and a myocardial infarction is all just a supply and demand problem. So if the if your supply is there, but you have some type of blockage, well, you're not going to be able to actually perfuse the tissues, and that tissue is going to die. Now, if it's a demand problem, if your heart's working too hard and you can't actually supply it because there's some type of stenosis, well, you're going to have that chest pain, and if part of those heart cells themselves start to die off, and you start to get release of that troponin, well, you're going to see an increase in the actual bloodstream. So if we're thinking about supply and demand, if we kind of talked about sepsis before, where the arteries basically go from a more normal tone, meaning they're not super dilated, to a more dilated tone, well, now you have more volume to fill. And if you're not increasing the volume that you have, and everything's just super dilated, well, less fluid is going to go to important structures like the heart. And so it's going to see a relative decrease in perfusion, a relative decrease in oxygen, and it's not going to function the same. And you can have some cardiac tissue injury causing that release of the troponin. And that's an example of what we refer to as demand ischemia. The demand is too high, and because of that, the heart's not able to actually perfuse itself well, and so you have ischemia or tissue injury because of it. Now, next is the BMP. The BMP is a good marker for congestive heart failure. It's not a requirement to diagnosing congestive heart failure, because congestive heart failure is a clinical diagnosis. You diagnose somebody with CHF based off of their clinical exam. But if somebody has a lot of fluid backup, your BMP is going to be elevated. Well, why is that? BMP is a marker of atrial stretch. So these are your atria of your heart. They are the top part of your heart where the blood comes in first before it goes into the ventricles. Now, if you have backup, so if your ventricles aren't working for whatever reason and you have backup of fluid, well, these atria are now going to be more distended. And so you have a stretch of that atria causing release of this BMP. And so this BMP will be elevated in the blood when you have backup of fluid, when you have this stretch, and you're not able to really push that fluid forward. So it's a pump failure. So if you're thinking about somebody in heart failure, CHF, you should consider getting a BMP to check to see if you have that fluid stretch of the atria. Now, lastly, we have the D-dimer. The D-dimer is a tricky lab to order because there is a specific criteria to order it. But we typically get a D-dimer if we are considering something like a pulmonary embolism. Now, a pulmonary embolism is basically a clot that comes from outside of the cardiac system. So it usually comes from the legs, but sometimes it can come from the arms. And it travels up, it goes into the heart here, goes down into the right ventricle, and then out into the pulmonary arteries. And so the pulmonary arteries are the vessels that go towards the lungs. And so this clot that was right here now travels all the way up, goes into the lungs, and gets stuck in the lungs. And so the lungs are now no longer able to get blood to them because you have this big clot in the way that is stopping all blood flow. And so if you don't get blood into the lungs, well, now you can't get blood out of the lungs. And so nothing is coming into the left side of the heart, and you're no longer able to perfuse anything out from the left ventricle to the rest of the body. And so if you have a huge clot, well, now you've basically shut off all blood flow going forward from the heart to the lungs, and so your pump fails because it's completely stuck. And so when that happens, those are the stories where you hear that a person's walking and they just drop dead because you have pump failure. You have a clot there That's not allowing for blood to move forward, and so your heart is no longer able to pump that blood out. And so it's important to detect pulmonary embolisms, but it's all based on how suspicious you are that that person has a pulmonary embolism. So that's where the D dimer comes in. The D dimer is not a very good test to rule in a pulmonary embolism or a deep vein thrombosis, so a DVT, but it's a good test to rule it out. So if your suspicion is low, but there still might be a possibility, well, if the D dimer is elevated, it can be a clot, but it can be a lot of different things. But if the D dimer is low, well, you have a very low likelihood that this is actually a clot, either in the leg or in the lungs. And so you can effectively rule out a pulmonary embolism with that. Now, I mentioned a DVT. A DVT is a clot that is in your leg that forms usually because blood pools and isn't moving. And whenever blood is stagnant, that's when it starts to clot, and it can form a thrombus that can be thrown up into the lungs. And so overall, it's very important to test to be able to check for PE and rule it in or out. But the D dimer is not a great test to rule it in. If you have a high suspicion of it, you would typically just go for imaging of the chest to see if you have a clot there. There's a whole criteria called Wells criteria to see what you should do in terms of getting a D dimer versus getting ultrasound of the leg versus getting just the CT pulmonary CTA pulm. But I won't go into that because it's probably a little bit more advanced than we need. But if you do want to check it out, I would recommend looking into the app called MD Calc. We typically use that for calculations we need in medicine in general, and it will save your butt many times over. So I would definitely look into it, and I'd probably recommend you downloading it now and get familiar with it, and in the future when you go into medicine, you'll be using it all the time. So I realized I didn't go over the actual lab values. So the normal lab values are listed here. So this is your white blood cell count, your hemoglobin, your hematocrit, your platelet count. This is your sodium, your potassium, your chloride, your bicarb, your BUN, your creatinine, and your glucose. So the normal values for the AST are 10 to 34, ALT 7 to 56, T-Billy 0 to 0.8. The lipase depends on the lab, so and refer to right now it's not that important, but I'll let you know if it's high or low if we do need it. The troponin less than 0.04, BNP generally less than 100, but that can also depend on the lab, and then the D dimer less than 500, but also the labs notate the units a little bit different, so just keep an eye out for that. So I know this was a lot, and hopefully I didn't overwhelm any of you guys. I hope the approach I took where I explained what each of these values were was helpful. Think of it as a guide, not so much that you have to memorize what each of these mean or what the values are, but more as what is it that I'm trying to look for? How is this lab going to help me narrow down my differential, and go from there. If you have any questions, feel free to comment or reach out. And if you want to keep continuing this effort, subscribe to the YouTube channel, like the video, share it with whoever you think would benefit. And I'm excited to be working with you guys soon.